Basic Needs Sri Lanka commenced in the year 2001 to initiate a new approach to mental health care in Sri Lanka. This was the Community Mental Health and Development approach, which was an alternative to institutionalized mental health model dominated then. The pilot project of the Basic Needs was implemented in the southern province of the island. Basic Needs recognizes the access to treatment for mental health is a right, not a privilege. It goes clearly with government policy which describes in 1978 Act as the people have the right and duty to participate individually and collectively in the planning and implementation of their health care. Basic Needs started its work with understanding and agreement with mental health policy in Sri Lanka. Basic Needs right-based approach was made practical with partnership with community members, local government, public health and non-governmental organizations. Their 5 working modules were insisted of community mental health, capacity building, sustainable livelihood, research and policy, The Basic Needs initiated its all programs with community consultations which were often center in its participatory approach. The community consultation workshop includes the members of community, people with mental health issues, family, government officials and Basic Needs staff. Trained animators who are skilled in communicating with people with mental health issues facilitated these consultations. Consultation workshop findings from each village were shared with relevant stakeholders and Basic Needs and used in developing local plans which turned Basic Needs model into practice and allocating resources to achieve outcomes for communities.
Consultation workshops are designed under 2 purposes. The main purpose is to consult mentally ill people, their carers and the community in order that we can develop a development plan based on their problems and also issues. The second purpose of this consultation workshop is to reduce stigma or sort of create awareness among the community about mental illness, and so that they will feel that this is not something different, it's just another illness. So we should not label or corner these people.
Mental health camps and follow-up clinics were another component of Basic Needs approach to people who living in the community with experiencing the mental health problems. This process took the professional medical care to the people who did not know they had mental health problems, who refused to go to clinics run by the state hospitals or who could not travel for far clinics due to their health or economic situations. This camp was conducted by a professional team of psychiatrists, medical officers of mental health, counselors, pharmacists, nurses and occupational therapists. After the mental health camp, monthly clinics were organized at the public health centers. This ensured the close link between the program and the public health sector. Participants who were unable to visit the clinics were helped through home visits by psychiatrists, medical officers and volunteers. After making effective progress and working extensively, the State Health Administrative have also shown greater willingness to recognize the program and the outcome and challenge their ability to adapt to this sort of community-based service. Community volunteers were a vital part of Basic Needs mental health development program. The volunteers were trained to improve their knowledge on mental health and work with people with issues. Then they were given responsibilities from identifying people with mental health issues to bringing them to clinics and following up their progress. However, not all medical professionals immediately recognize the role of community volunteers in the provision of mental health services. With all the challenges, the volunteers were able to win the hearts and minds of the people, and they were loved by the people who were mattered because of the positive impact the volunteers made on their lives. By the end of 2010, there were 2,040 active community volunteers in the program. A woman, man or child, the household who takes care of the needs of a person with mental health problems are called carers. The Basic Needs Mental Health Program acknowledges the vital role of carers and the need to strengthen the capacities of them. Women comprised almost 60% of the total carers in the program.
What kind of common problems are faced by them. Interestingly, the main problem was that faced by them was the stigma, discrimination and exclusion from the community was on the top of the list. Second was the livelihood options, the problems that they are facing with livelihoods, their economic conditions. Third, the carer who takes care of their burden was pointed out. And the fourth was the problems that they are facing because of the illness was on the list. Then its list goes on. But it was very interestingly that for us, how much ever the mental health services were given or how much ever that we have done programs, the stigma is very largely felt among the mental health service users and their carers, and it's still at large.
A small group called Self-Help Group, which consisted of people with mental health issues, was formed to address social stigma and discrimination at local level and to build their capacity and confidence through peer supports. Self-help groups have helped people gain their self-respect, their dignity, and the ability to voice their rights. When people with mental health problem begins to recover from step by step, they were motivated to participate in productive work, such as helping family at home to starting an income generation work or a livelihood. The livelihood program centered on the person with illness. It was expanded to build the capacities of carers and family members to get the maximum advantage of it. Their capacities were built in the areas of income generation activities to expenditure and skill management of family. Creating knowledge and advocating for positive changes in government policies was another task of the project. Basic Needs recognizes the advocacy can promote the rights of the people to achieve mental health care and opportunities for social and development integration. The implementation of the Basic Needs Mental Health and Development Program is in itself an advocacy initiative. The people with mental health problems were at the center of its advocacy activities from the beginning. The Basic Needs empowered these people to build their independent user-led mental health advocacy organizations. The state's increased recognition of professional care to facilitate mental health care was demonstrated when they requested Basic Needs involvement in addressing mental health challenges of the post-war situation in the North.
On 26 December 2004, a series of
Tsunami disaster in the year 2004 surged a need of mental health care service in different contexts in which thousands of people had lost their loved ones, livelihood and properties. Basic Needs visited the affected areas and consulted the affected communities. This led to development of psychosocial program in which Basic Need worked with the affected communities to help them to rebuild their lives destroyed by tsunami. As a part of this program, 8 camps with professionals from the state sector were settled just 4 days after disaster were held to provide emotional support to the people. Then the psychiatrists recommended mobilizing basic needs community volunteers for the cause. Finally, Basic Needs trained and occupied 694 new volunteers, and they have served over 13,000 people in need. Basic Needs trained government and non-governmental staff to deal with the overwhelming mental health issues that had to be addressed. Basic Needs Mental Health and Development Program generated new information, insights and knowledge that reflect the realities of people with mental health illness and their communities. They researched and documented their programs, and the results of these programs were shown using different methods, including participatory research. The findings from these studies were used to improve the program's quality and to produce new knowledge.
වර්ෂ 2002 සිට මේ දක්වා දකුණු පළාත මූලික කරගෙන ක්‍රියාත්මක වුණු මේ ප්‍රජා මානසික සෞඛ්‍ය වැඩසටහන මම දකින්නේ මේ රටේ මානසික සෞඛ්‍ය සේවාව නව ප්‍රවේශයකට යොමු කරායි කියලා. අලුත් දිශාවකට හැරෙව්වයි කියලායි මම දකින්නේ. එහෙම කියන්නේ කාරණා හතරක් මුල් කරගෙන. පළවෙනි කාරණේ තමයි මෙතෙක්කල් මානසික සෞඛ්‍ය සේවාව සීමා වුණා නගරවලට මධ්‍යගත සේවාවක් හැටියටයි අපි ලබා දුන්නේ. ඒ මධ්‍යගත සේවාව අපි විමධ්‍යගත කරා මේ වැඩසටහන තුලින්. සරලව කිව්වොත් අපි මානසික සෞඛ්‍ය සේවාව ගමට ගෙනිච්චා. ඒ පළවෙනි කාරණේ. දෙවෙනි කාරණේ තමයි මෙතෙක්කල් මානසික සෞඛ්‍ය සේවාව රෝහල් මූලික සේවාවක් හැටියට තමයි ක්‍රියාත්මක වුණේ. රෝහලට පැමිණෙන සහ සායන වලට පැමිණෙන රෝගීන්ට පමණක් සේවය ලබා දෙන සේවාවකට සීමා වුණා. මේ වැඩසටහන තුල රෝහලට පමණක් නොවේ රෝහලට එන්න බැරි එන්න අකමැති සේවාලාභීන්ව ඔවුන්ගේ නිවෙස් වලටම සොයාගෙන ගිහිල්ලා ප්‍රතිකාර කරන ලබා දෙන සේවාවක් බවට පත් වුණා. ඉතින් මම හිතන්නේ ඒක ඉතා වැදගත් පියවරක් හැටියට.
Basic Needs paid their special attention on improving children's mental well-being. The initial program, which was called Creating an Enabling Environment for the Integrated Total Well-being of the Children by Addressing Their Mental Health Needs and Rights, was started in the districts of Batticaloa, Galle, Hambantota, Mathura and Vaunia. The project worked with children from schools, children's clubs, certified remand homes and special needs homes. The project aimed to create a stronger, better resourced, more knowledgeable environment to promote and protect the needs and the rights of children who are vulnerable to mental health problems. What has been the naval intervention for the program was, for the first time, the children were consulted to explore what they have been through and what can help them to improve their well-being. Social connection and participation, self-worth and competence, access to physical material and intellectual resources, physical and psychological well-being were identified as key areas that affect on their well-being. The second part of the children's project, creating a supporting environment to promote the well-being of the children in the Batticaloa district. Batticaloa was the only district chosen for the implementation of Project 2. This was to enable interventions that are more focused and intensive of the 3 decades of violent ethnic conflict. This had exacerbated Batticaloa's already poor economic conditions and caused deep psychosocial impacts. The project worked closely and actively with community-based children clubs identified by Project 1 as an ideal means through which children could have positive peer interactions and form crucial social connections. In parallel, it engaged with educators, parents and government institutions and officials mandated to work with children. Perhaps even more importantly, it facilitated engagement between all stakeholders so that they could hold each other accountable for ensuring children's physical, emotional and mental growth. In the last 15 years, Basic Needs has reached 18,000 people with mental illnesses and over 30,000 community members in the districts of Hambantota, Mathura, Galle, Ratnapura, Trincomalee, Batticaloa, Anuradhapura, Puttalam and Colombo. The path of success for the Basic Needs was their mental health and development model, which grounded in principles of inclusion and rights-based approach to development. After a decade-and-a-half-long journey of challenges and success, the project has come to a closure now. The sustainability of Basic Needs involvement will be tested by time. Basic Needs tested approach and research findings are now available for its partners to carry on from hereafter.